Okay, so it's a privilege to be able to moderate this final session for the group. We promise to make interoperability and integration fun and exciting as the final session on an afternoon here. I have the privilege of actually hosting with 4 colleagues that are national experts in a lot of the topics we'll talk through, and so want to save as much time as we can to be able to have a dialogue at the end. I think based on the conversations we've had through the sessions this morning and this afternoon, we've started to cover a fair amount around where that value proposition comes from around integration. I think the last panel we heard was actually outstanding. I started sort of changing some of my commentary here this morning or this afternoon because I think it does highlight the fact that scheduling and scheduling systems and what we're trying to do with really intelligent, effective scheduling adds value in terms of how we're actually trying to promote health for our veterans and our veteran communities. And I think you saw a lot of that in terms of what the folks at the table were saying they were trying to do in order to help the veteran, or even what the veteran was trying to do for him or herself as they were trying to get to a better stage in terms of healthcare. And so I think this is going to be interesting because our panelists today do come from the technical side of things. We have Chris Ross joining us from the Mayo Clinic. He'll launch us out, but he'll talk a lot about, I think, a commentary. Maybe it was Ken or maybe it was Don who brought it up around doing that sort of itinerary level scheduling that Mayo does around being sure that when a patient comes into Rochester, Minnesota, they are trying to maximize the sequence of those visits to be sure that that clinical progression towards diagnosis or treatment happens as rapidly and succinctly as possible. And so Mayo has a fair amount of sort of experience there. We'll flip and actually have Isaac then go next, and he'll talk a little bit more from the Epicare or the EHR vendor perspective and talk through what is a vendor thinking about as they're trying to link through some of those functionalities that, again, we've been talking about. And then some senses, then we'll shift over to have Sagnik from Patient Ping talk from the third-party vendor perspective and saying, as they're trying to link together things, particularly in his space where he's talking about a lot of hospital ADT information, discharge transfer information, that can be the signaling point for when patients are moving from one location to another, and can we use that to automate pathways to be sure care transitions are happening in a very appropriate way. So this will be an interesting spot for Sagnik. And then Robert actually will close us out coming from the California HIE perspective, saying there is a lot of this going on, not just within the Veterans Administration, but also within the ACO accountable care world. I'm coming from Atrius Health. We're sort of the old physician side of Harvard Community Health Plan, and so we are a practice, a multi-specialty practice, without hospitals, without emergency departments, without skilled nursing facilities, but we take full capitated risk for the populations that we serve on the Medicaid, Medicare, as well as the commercial populations across multiple payers. And so we absolutely share the vision that the VA brings to bear around how care coordination is critically important and mission critical for an organization like ours, particularly as our patients are dancing in and out of the Beth Israel Deaconess, the Brigham and Women's Hospital, and back in with our own ambulatory system of care. As we were listening to the panelists before, too, I couldn't help to sort of think through and saying we've got different names for a lot of the functions. We don't have the travel coordinator part of it, but we have an intensive home-based care system. We have a hospital-at-home program, and all the things that we're trying to knit together. So part of the questions and part of some of the things that I would ask our panels to be commenting on is that while the Veterans Administration is unique in many ways, particularly in its scale and its complexity, some of the functionality that I think you're going to want to be bringing forward into the new VA systems, I think you're going to see some pretty good examples in the commercial-based sector as some of the same pain points or the same problem areas. Don's going to sort of say, don't do a pain point. But that idea of solving what we need to do to coordinate care very well, I think is similar. I think there's some great lessons learned from that particular spot. Before I launch in, I do think that we've been referencing the 2015 report from IOM in many senses, but my session or this session may be a little bit different in that I reference a different National Academy report. It was the report that Peter Pronavost's team, and I think John Halamka and Chris Ross was on, really thinking about procuring interoperability. This was released in 2018, and I think there's a lot of really great lessons there around what does a system do, both on a payer perspective or a provider's perspective, in order to procure interoperability when they're moving into a new system. I think that report, like the IOM report, was at a high level, and so a lot of theory and a lot of constructs. Hopefully today's sort of panel will take a lot of those principles that are articulated, but then move them down to a very specific use case around scheduling systems and saying interoperability and the concepts there are really important. Integration is really important. Let's use scheduling as the case example to illustrate why these things are critical. I'll go further, and then I'll go ahead and launch into our panels and say there was two constructs that I found particularly compelling out of that report that I'd like to pull over into our panel today. One was the concept, and these were two things that they exploded in far more detail in the 18 report, but the idea that interoperability has very different sort of ways of describing it. Interoperability does not mean interoperability does not mean interoperability, and it gets bantered around as a single colossal term, but it means a lot of different things. And the first construct I'd submit that is important to keep in mind, and I ask for a little bit of forgiveness, this might get a little nerdy, but the idea of interoperability being there are 4 levels of interoperability. The first level truly being technical interoperability, and that's really the ability to sort of exchange data back and forth in a secure fashion. But then you move into syntactic interoperability, where the form of the data that's being transferred actually has some structure to it, so the exchanging parties can infer certain things. Then you move up to a next level of semantic interoperability, where there's a common sort of vocabulary being used in the information being shared. And finally, you move up to organizational interoperability, and that's a place where you've got not only all of the things below it, but you've got this understanding and a clear understanding between the two exchanging parties that you can start to drive automated workflows from data coming from one organization to another. And there's an incredible power in that when you actually have that kind of synergy, but it's important when we talk about interoperability, at what level are we talking about? Because in many times you talk about these two technologies are interoperable, but in many senses all it's doing is exchanging at the purely technical level, and it's hard to get some of the value that many of us are really thinking or aspiring to get out of scheduling systems. So keep that construct in mind: technical, syntactic, semantic, and then organizational. The second construct that I think I'd bring forward is the setting, or maybe the different tiers. They called it tiers of interoperability. And they talked about it at sort of the macro level, the meso level, and the micro level. And the macro level truly was organization to organization. So if at the veteran system to an outside community provider or pharmacy, CVS, Aetna, if that's the direction that things are going to go in terms of partnerships, that's kind of macro level interoperability. The meso level is within an organization. I think this will be within the Veterans Association, the hospital systems, or the ambulatory settings. Chris will talk a little bit about that as Mayo Clinic, as a single enterprise entity, trying to make sure that all the systems within the Mayo Clinic connect with one another effectively to be able to provide that kind of interoperability. And then finally, we talk about micro tier or micro level interoperability, which is truly point of care interoperability, which is a lot of the devices, the things that are little Apple Watches, a lot of the things that are happening in place with patients in that sort of Internet of Things type environment. And again, there's a lot of different things there that we think about, but those 3 levels and settings are also an important part to consider when using the term interoperability and thinking about what does it mean in the construct and how do we integrate. So, again, that's the sort of the semantic vocabulary background for the time. I'd love to be able to turn it over now to Chris, who is joining us from Rochester. I'm going to wait for his video to pop up and invite him to share with us a little bit about how the Mayo Clinic thinks about this and has operationalized it for the clinic.